Hello, everyone. Welcome to today's webinar focused on Indigenous perspectives on patient safety. On behalf of Patients for Patient Safety Canada, the patient-led program of the Canadian Patient Safety Institute, and the Canadian arm of the World Health Organization Patients for Patient Safety Canada, Patients for Patient Safety Program, it's my pleasure to welcome you to this session. My name is Ioana Popescu. I'm a Senior Program Manager with the Canadian Patient Safety Institute, and today, with my colleague Janet Bradshaw, we are honored to host you. Before we begin, I would like to offer a few practical tips about the session. All of the lines are muted as you join the webinar, so please pay attention to that. And if there's background noise, you can double mute yourself. The dialogue today will take place primarily via chat. So if you put the mouse in the middle of your screen, you will see some buttons popping up at the bottom. One of them is the chat button. Click on that, and then you can send a note to everyone. We should try to practice that for a little bit. So click on the chat, then go to the right-hand side portion of your screen and send a chat note to everyone. Tell us where you're calling from. Your city and your province should be enough, and that way we will have the conversation going. We have asked in the registration form about your goals or questions about the session. We have collected all that, shared them with the participants, and we will use your questions during the Q&A, but also use the chat as you may have new ideas popping up as we proceed through the webinar. I see you're doing a great job using the chat. Wonderful. And you also notice that you can send a note to all participants, all attendees, or you can select a person from the list. On purpose, we allowed all the names to be visible, just like you would see them on the name tags at conferences. So feel free to also send a private note to anyone who is attending the webinar today if you feel like. But if you'd like all of us to pay attention to your questions or comments, make sure you choose all attendees. The session is recorded today, and it will be posted on our website after the webinar. We're doing that for people who obviously cannot be here today. Oh, hello, Marilyn.
Hi. I didn't know if this was a...
Yeah, I think you're in the right spot. This is Ioana, just going over the logistics, and very soon we'll pass it over to you.
Okay.
Yeah, so a few more tips. The session is recorded and it will be posted on our website. However, the chat conversation will not be part of that. So don't worry about typos or anything in the chat notes. That is just for us who are on the line today. So now I would like to welcome our host for the webinar and our moderator, Marilyn. Marilyn Shingus was born in Kamsack, Saskatchewan. She is Saulteaux and belongs to the Cote Nation Treaty 4, which is also in Saskatchewan. Marilyn has a passion for the Truth and Reconciliation call and works to educate people on the history on how we got to where we are today and why Indigenous people are affected. She's a facilitator, trainer, and coordinator in the Calgary area. She's also a knowledge keeper, wisdom keeper, and elder for Kairos. Marilyn comes from a big family. Her mother and 8 siblings were taken to the residential school system, so her story illustrates how this affected multiple generations. Marilyn, it is an honor to have you on our webinar today, so I would turn it over to you for some welcome comments.
Hi, welcome everyone. Good morning. I really believe that this is very important to learn about. From my perspective, it goes back into history with the Indigenous and how they use the medicines and so on to get well. But I know how patients have been treated over the years, and I've had personal experiences of that. So I'm looking forward to this webinar and your questions. I'm going to move on to Samara, introduce you to the panel speakers. Samara Cardinal is a Kainai Métis from Southern Alberta and a member of Patients for Patient Safety Canada. She has over 20 years of experience working with diverse populations in mental health, addictions, in the disability field. She is currently a social work student at Mount Royal University who works in the addictions and medical cannabis fields. Alec LaFontaine, Dr. Alec LaFontaine is an award-winning physician, speaker, alignment consultant, and the first Indigenous physician listed by the Medical Post as one of Canada's 50 most powerful doctors. He is recognized expert on Indigenous health systems and health policy, institutional bias, racist, and reflective practice. We can't list all of his accomplishments, so we will highlight that he played a key role in building an Indigenous Health Physicians Association of Canada and is the medical director of the Northern Indigenous Health Program with Alberta Health Services. He lives in Grand Prairie, Alberta with his family and continues to practice full-time as an anesthesiologist. Gina Gaspard was born and raised in the beautiful East Kootenays of British Columbia, traditional territory of Kootenai Nation. She has been a nurse for over 30 years, joining with First Nations Health Authority in their Vancouver office in 2015. Her role is a clinical nurse specialist for healthy living, chronic disease, and end of life. Her interest is supporting nurses plus promoting healthy living throughout the person's trajectory of chronic disease through to final days. So those are the three panelists that will be telling their stories and answering questions. We can move on to back to you, Mariano.
Sure. So maybe I'll invite Samara now. This is just the outline for our program with the order of the speakers, and there will be Q&A right after. So why don't we dive right in? Samara, over to you.
Thank you, everyone. Can you hear me?
Yeah, I can hear you.
Okay. My name is Samara Cardinal. I am but one story in a sea of thousands. I speak for those who cannot speak. And I hope that I encourage to others to speak their truth also. I am a second-generation residential school survivor whose father did the best he could, but had no idea how to effectively parent. As a result, I was abused and traumatized as a child. After I had my daughter, I experienced postpartum depression, and as a result, I ended up hospitalized in a mental health ward. When I was there, the doctor diagnosed me with bipolar disorder. That diagnosis changed my life. I was with a medical team for over 10 years that over-medicated me and had me go through biweekly shock treatment for years. During this time, I went up to over 300 pounds, lost my driver's license, could not parent my daughter, as most of the time I was sitting in the living room literally drooling. I lost the relationship I was in. I was put on AISH, which is government disability. Every time I went to see the doctor, I was put on more medication, and medication was continually added for the side effects of the other medications I was on. I ended up being on over 15 medications. During this time, I started experiencing memory problems and was tested by a psychologist in the hospital. When the results came back, they told me I must have lied on the test. The reason why they believed I was lying, as the test results showed my memory was worse than an Alzheimer's patient. I was devastated by the accusations. The medical team was continually losing my trust. When I was younger, I believed doctors were like gods. They knew everything. They could help with everything. During my life, I found out they make mistakes. They are not gods. They are just people whose mistakes can seriously affect other people's lives. One day I went to see the doctor. I was feeling quite ill. I was disassociating. She accused me of lying and faking my symptoms. I had had enough of them. That is when I fired them. As a result, I was walked out of the hospital by security guards. So embarrassed and demoralized. However, looking back, that was a great day and it changed my life. I found a doctor that only put people on medication when they needed it. He never over-medicated people. With his help, I got off the 15 medications and am now on none. Since then, I have been told by multiple doctors I never had bipolar. I have PTSD. I have trauma, and I have intergenerational trauma from years of multi-generations in my family being put in residential school and being affected by colonialism. So I was misdiagnosed and went through all of that for nothing. I still have tardive dyskinesia as a result of being given long-term doses of antipsychotics. This diagnosis still follows me. A few years ago, I went to an emergency because I had pain in my chest. There is a history of cardiac problems in my family. The ER doctor came up to me and asked me if I was taking my medication. I knew what he meant, my psychiatric medications. I was angry and asked him what that had to do with that pain in my chest. Now I am back at university in a wonderful relationship, own my own home, and contribute back to society and a system that tried to break me and my family. I believe I was treated poorly and misdiagnosed by the healthcare team because they had no idea about what Indigenous people have gone through or even understand our culture. I believe anyone going into the medical profession should learn the true history of Canada and what the government did to our people. I'm doing this webinar today, not in anger or to point fingers at anyone. I just want healthcare professionals to realize the impact they can have on a patient's life, how the diagnosis follows them, and how it affects them. I really think about the label you're going to be put on another human being. And as a result of my experience, I no longer trust medical professionals. Everyone I interact with now must earn my trust. And unfortunately for me, it's quite a long process. Thank you very much.
Thank you, Samara. So we're going to go on to some, if you have any questions, we've got like about 5 minutes to answer any questions anyone has.
Marilyn, maybe I will pick a few questions from the registration form, if you don't mind, while our participants think of what more to ask. Thank you, Samara, for your story, how powerful it was. Several of the people who are attended registered for the webinar wanted to learn how to be mindful of the needs of Indigenous people. What advice do you have for them?
I think it's really important that we all carry biases, and as a result of everything we hear on the news and stuff, everyone does carry biases. And when you're a non-Indigenous person and you're working with an Indigenous person, please be aware of those biases you carry and try not to cloud your interaction with them, because we are all separate people. We are all just like anyone else. And to treat us differently and to treat us less than is not a good thing. Try to understand us. Look at the person's past. Look at what they've been through. Connect with them as an individual. That is what is important.
Mm-hmm. Thank you for that. I will invite maybe Alika and Gina to add on advice how to avoid this bias.
Why don't you go ahead first, Gina?
Well, I guess I will start to say that I am not Indigenous, and so this has been a learning journey for me as well. It's a question that I've asked myself many times, and I think the briefest way to be able to capture it is to lead with curiosity rather than judgment. And if we're curious, then we can't judge others.
Thank you.
Sure, and it's Alika. I'll just add to that. I think sometimes we mix biases in with judgments that we make that create an ease to the way that we practice. As a physician, if I'm seeing 40 to 80 patients a day, it's difficult for me to actually reflect on every single patient in every moment during that day, just because I'm overwhelmed with the amount of work. And so a lot of times we use these biases in order to streamline what we're doing. I think when you run into situations where patients have adverse experiences, or when patients run into conflict for very good reasons, because they're either advocating for themselves or they're advocating for a family member, or because they're trying to share personal experiences like was just shared by our first panel member. Often it's tough for patients to work through these labels that providers are throwing onto them. I'd really encourage patients just to call it out. If you're experiencing racism and you feel that the provider is pushing you into like a corner, I've heard providers get medical histories on patients and insist that, they're alcoholics when the patients tell them, I've never drunk in my entire life, who have insisted that this is from diabetes, even though there's no real evidence that moves that way. Just like was said, providers are human too, and a lot of times they're trying to work through kind of the amount of volume that we're trying to get through using things that streamline our work. But if you're experiencing harm, the very best thing for you to do is just come out and say it. I would say in the majority of situations, providers will be receptive. In these situations where they're not, it is your right to be heard. It is your right to be a co-designer in your care. And if you're not getting what you need from that provider and you can go to someone else, I encourage that. If not, there's mechanisms within the system that need to do their job and actually fix these problems for you.
Mm-hmm. Many thanks to both of you. I see we have some live questions. One, I'm going to ask Samara, maybe Marilyn, if you would like to speak up to what aspects of Indigenous culture are most important for healthcare?
Marilyn, would you like to answer that?
I was just going to say something. I know within our culture, they're called medicine men and women. If there's health issues, usually we go to an elder and then we go to this medicine man, and they'll usually do whatever they need to do with you to determine what the problem is, and then they do the medicine, like from herbs and from roots and all kinds of different things. And they'll mix that medicine up and do treatment for these people, and that's how it's done from our culture.
Mm-hmm. I just wanted to say what aspects of Indigenous culture. Well, we are not pan-Indigenous. We all have our own separate cultures. You cannot lump us into one big, huge group. So it's very important when you're, say, working with someone to find out where they're from, find out what their culture is, and, understand the cultural differences that occur, in the communication and everything. I think it's really important for non-Indigenous Canadians to learn about this because through learning, we break down the doors and we create understanding. It is the myths and the misjudgments out there that is causing all these problems. So take it upon yourself and learn. There are communities out there that would welcome you if you want to learn. I don't know of any community that would push you away if you wanted to learn more.
Mm-hmm. Thank you. We have lots more questions. Let's maybe ask one more and then move on to Alika's presentation. One question is about clinical assessments who are standardized. How can a hospital or healthcare provider ensure that we are embracing the relevant cultural aspects when we're screening patients?
So I'll maybe add to this first. It's Lika. I think although we do have clinical care pathways and there are, clinical practice guidelines, etc., the reality is we don't monitor them and we don't have robust mechanisms within systems that when people deviate and can't justify their deviation, that there's some sort of way to improve clinical practice. So although these things are in place in actual practicality of medical provision, we don't always follow them. And there's sometimes good reasons for it, and there's sometimes reasons that are not that good. I think when you're looking at the relevant cultural aspects when screening patients, what's really important is something that came up previously from another comment, which is we need to see patients as people, not as patients. And we've tried to do this in some of the movement forward. We've relabeled patients as clients in some situations. We've talked about customer service, etc. At the end of the day, if a patient doesn't feel like they're treated like a person by their provider, they won't share what's actually going on. And when they have adverse experiences, they'll be afraid of repercussions. And from a provider point of view, if they don't see people as people and not as a patient just in a sea of other patients, it'll be really difficult for us to tailor care in a way that's most effective for them. And so it's a two-way street when building a relationship with the power dynamic between providers and patients. I think the big onus is on the system to be the one to really help to change and shift that. But clinical assessments, I think, are just one tool in the armamentarium of clinical decision-making. But the more important tool, at least in my own personal practice, is that we self-reflect on whether or not we're actually treating that person across from us as a person.
Yeah. It's a great comment. We have got a few questions about engaging Indigenous perspectives in policies at organizational and system level. But I would say let's listen to your presentation, Alika, and then we can continue the conversation with our participants. In the meantime, all of you can participate, answer questions that your colleagues asked in the chat box, and let's keep the conversation going. Alika, over to you.
Sure. So thanks for inviting me again. My name is Alika LaFontaine. I was born and raised in Treaty 4 in southern Saskatchewan. My ancestry is Ojibwe, Cree, Métis, and then also Pacific Islander, so Indigenous from many, many different sources. Just for those who are attending, I added my Twitter as well as my email in case you want to continue the conversation later. I know an hour is not enough time for us to solve all the problems with Indigenous patients and patient safety, so hopefully this triggers other conversations that will continue on. I wanted in my presentation to really outline two key takeaways from my work over the last 20 years in Indigenous health, and also share how a small group of providers and patients that I work with are increasing Indigenous patient involvement with reporting adverse experiences in something we call the Indigenous Patient Empowerment Project. So the first place that I'll focus on is a bit of research surrounding ways that we report concerns. So the first thing that I'll note is that there's not a lot of research in this area when it comes to specific reporting and whether or not that reporting reflects how many concerns are actually out there. So we know from worldwide literature that have been repeated in several parts throughout the world that patient concerns out of all the people who come and visit hospitals, about 10% of those encounters end up involving an adverse patient experience. So an adverse experience I define and most people define as something that either lengthens your hospital stay or leads to some sort of long-term disability or difficulty or some sort of worse outcome. So about 10% of all hospital encounters will have an adverse experience. So there was a study out of Denmark that reviewed 5,000 patients. There were groups of clinicians who actually went in and used a standardized way of evaluating whether or not something had happened based on the patient chart that should have been reported by the patient. And then they compared that against the actual complaints that were received within the health system. And what they found that only 3.6% of all those adverse patient experiences that could have been reported were actually reported. So that number's really small and should be shocking to most people, 3.6%. But in my own anecdotal experience with different healthcare organizations across the country, this actually lines up with people's sense of how many adverse experiences we're actually capturing. So we probably capture only about 5% of actual experiences, which is a really, really small slice of everything that's happening. Now, considering all of the improvements in quality and safety that we've been able to achieve with that small amount of stories, it's very impressive what we've been able to accomplish, but imagine what we could do if we actually unlock that up to 95% of stories that never get shared. So why do patients not report things? So research has shown that as events get more intense, providers report less, and patients are also less likely to assert themselves within these experiences. For example, if you have some sort of adverse experience when you're receiving chemo treatment, a patient will be much less likely to contribute their experiences because cancer is a really intense experience and treatment for cancer tends to be very complex. This means in general, adverse events that get reported are at lower rates, and as things get more severe, so the ones that will really make an impact if we knew about it are even less likely to be reported. In rural and remote locations, or I'd add to this situations where patients either show up as a smaller group of people, so chronic diseases, rare diseases, there are unique ethical considerations. Things like a lack of confidentiality because it's such a small group of people, or because systems or infrastructure don't exist to protect that confidentiality. Sometimes you get a mixing of personal and professional relationships. You know, you golf with your doctor, or, you know, you go out for dinner with your nurse. And sometimes you get people who have double identities. So you may serve on a board of a nonprofit in a small community, and that person is also chief of staff over at the hospital. So I also consider that for single providers, even in urban systems, residents are often assigned to receive care from only one place. So an example that I've heard repeatedly from Indigenous patients in BC is that they're assigned to a health region, and even though they may live in a different place within the province, their First Nation is within that health system, so they can only receive certain types of care there. So the first takeaway, and I hope that people on the call feel this, a lot of these issues are universal. They're the same sort of issues that any patient would deal with when having care within these specific types of contexts. And so the key takeaway here is that Indigenous issues are a magnification of existing issues. And you can link to that unique historical and structural contexts. So when solving these problems, it's important for us to come from the frame of what we already know from patients who experience these things. When a patient is asked to share their experiences, particularly the adverse ones within existing systems, there's often no confidentiality clause within health complaints and concerns. And for those who've actually gone through complaints and concern mechanisms, you probably found that your confidentiality is protected until it's not. And I've experienced this when I've been a part of, looking at colleagues or providers improving their practice, or when I've advocated for patients moving through the system. Often you get told that your confidentiality will be protected, but there comes a part when it comes to due process where the system just won't or can't provide that shield of confidentiality anymore. And so this leads to the second takeaway, which is to have patients fully engaged in patient safety. We have to address their fear of the process. And it's not a fear that arises from ignorance, in my opinion. It's a fear that arises from either their personal experience or the experiences that they know of other people that deal with either repercussions from reporting. So changes in the context of your care, your doctor or provider treats you differently. Sometimes in Indigenous communities, particularly those in remote locations, there's been outright denial of care. And so to have people access reporting systems, actually share their adverse experiences, we have to get to the point where we can actually deal with this fear. So how do we solve these barriers in our Indigenous Patient Empowerment Project? Well, first, we have a focus on creating safe spaces to share experiences. Confidentiality and empathy are the most important parts of this. So if you're looking at creating your own, those are two very, very important components to it. And just keeping in mind, like I said before, health systems can't guarantee confidentiality as they are required to provide due process and investigations. So we need to consider new ways of sharing experiences, and sometimes that may involve structures that we don't traditionally look at. Second, we have to believe patient experiences as a rule. The very last thing patients need when sharing their experiences is for them to be interrogated or for their experiences to be minimized. Patients in our project don't have to convince us that what they experienced happened or that it caused harm, and whether that harm was physical, emotional, mental, etc. The third part is we need to contextualize the experience for the patient. How does this compare to other experiences? Should you accept this experience as something that's normal within the existing system? What are the reasons that we could offer that explain either this as like a common issue or a one-off issue, both looking at empathy towards the providers and system that are involved? And the fourth is we bring together stakeholders to discuss places and patterns, not persons and specific incidences. And in that way, I think we can make the biggest impact in what we're doing. So I'll leave it there.
Thank you. Yeah. We'll move on to any questions. Answer some questions for anyone out there.
So Maria and Gina, maybe you can react or add to Alika's comment.
I just wanted to say, yes, it's so important to for the patient if they've had an adverse experience to help them speak up. Like my experience initially happened years ago. I was traumatized, I was over-medicated, and I felt powerless. And then when all this happened, I went to some health professionals. I got the forms to report everything. And then I was told that if I did that, no health professional would ever work with me again. So at the time, I didn't realize that that really wasn't necessarily the truth, but I was afraid and I didn't know the system. So I kept silent. Mm-hmm. And now I realize that that isn't the case. But at the time, I was a disempowered individual that was terrified. So I went along with what I was told.
Mm-hmm. Yeah, I think patients often underestimate the power that they hold and overestimate the power of the system. But just looking at that threat, if you're there and you need care, and we exist in the public system where everything is regulated more and more through organizations that are consistent across geographical regions. I mean, you're talking Alberta Health Services, not a health region anymore, right? It's terrifying for patients. And I don't think we speak openly enough about that. I mean, we talked about clinical practice guidelines, but also the application of, this just culture concept within health systems where everyone is treated fairly and non-judgmentally. The truth is, if you have a complaint come in as a provider, it is very risky for your professional career. There are providers that have considered just giving up medicine completely after receiving complaints. And I think patients understanding the emotional arc of what providers experience will help inform them in advocating for themselves more effectively. But at the end of the day, if somebody did something wrong, they just did something wrong. It's not the responsibility of the patients to somehow quantify or mitigate that for the provider. It's the responsibility of the system to fix it.
Mm-hmm. Good. Alika, we got lots of questions in the chat. One from Carol wants to know a little bit more about the empowerment program that you mentioned earlier.
So what the project is really about is creating a third-party repository for patient experiences. And what we do is we bring in experiences in the same way that the Conquer Silence campaign that CPSI is putting on is collecting experiences. And what we really emphasize through the process is at the end of the day, your story is your story. Patients often get the implied idea that somehow when they report a complaint, they can no longer talk to anyone about what they experienced. And somehow that will adversely affect the effectiveness of whatever the process that they're going through, whether it's at the health region or the regulatory body, et cetera, et cetera. We're really about collecting these experiences, aggregating them using artificial intelligence and machine learning so we can start to see patterns and distributions of care. For two reasons. The first is so patients know when they go a certain place, this is happening, and I'm not crazy when this experience happens. I'm not kind of a one-off case. It's not my fault for showing up late. It's not my fault for not being able to explain myself concisely, et cetera. You know, all the reasons why patients blame themselves for what they're experiencing. The second part of it is to actually help patients improve the way that they report. So how do we support patients to understand how to share their concerns, what the system is looking for, what are the restrictions placed on the health region for actually moving forward with a complaint? Because for Alberta Health Services, for example, if we receive a complaint, we can deal with issues within our facilities, but we can't deal with complaints in private physician offices elsewhere. But for patients, that's just part of your continuum of care. So how can we relook at how to report experiences that accommodate the natural way that patients move through the system instead of what's easiest for the system?
Yes, I love that comment. Even if we reflect back at Samara's story, it spanned over several providers and many years. So what do you report out of that, right? So that's good. Back to the participant question, several people asked in the chat box for advice on creating the safe spaces.
Yeah, so my number one requirement for a safe space is not interrogating the experience. And this is really difficult for individuals, especially when harsh truths are shared. You know, if you have a space that involves, you know, a provider and the provider has been, has gone through a complaint or other mechanism, it's very natural emotionally to kind of rise up and defend a colleague or other people, or to push back on patients and say, you know, it's not as bad as you think, people are overworked and all these other things. If you're creating a safe space, you have to eliminate that to a great degree. Patients have to feel safe that when they say something, they're going to be implicitly trusted, and that with that implicit trust comes like an accommodation that this is what they experienced. You may not agree with it, but you shouldn't do anything that could be perceived as minimizing it or dismissing it. So that's the first piece of advice. The second part of safe spaces is making sure that there's strong boundaries in place so people know what can and can't be used with the stories that are shared. Sometimes within safe spaces, people share things as, personal therapy. You know, I often share experiences within safe spaces about, traumatic events that happen at work. It's really important for me to know that those experiences won't just be passed along without any clear understanding of what will and won't happen as we're sharing the experiences. So those are the two places I'd start. They sound simple, but they're very, very difficult to implement in reality. And if people have other questions, they can always contact me directly.
Okay.
It's Gina. I think I agree with that and would like to add safe space is also, I think, about as a healthcare provider, being aware of the power difference, just the fact that I'm a healthcare provider, and in every possible opportunity, leveling that power differential in giving up control, giving up power as much as possible. So letting people know where they can have control. So, for example, you can stop at any time and leave the room, or the things that they can and that they have control over, and the things that honestly they don't have control over, and just really focusing on that permission seeking.
Wonderful. Gina, in the interest of time, maybe I'll ask that we continue with your presentation. I'll invite everybody else to continue in the chat box the conversation. Melissa offered some nice comments about the safe space, so feel free to read what our colleagues on the line are talking about while we turn it over to Gina for her presentation.
Thank you. And thank you to Samara and Alika for some really thought-provoking stories and comments. I am not Indigenous, and I'm not an expert, and I'm definitely not a spokesperson. But I was asked to speak about a project and that I was lucky enough to be involved with. And before I start, I want to acknowledge that I'm talking to you from the beautiful Coast Salish, the territory of Coast Salish people, specifically Squamish, Musqueam, and the Tsleil-Waututh. So, as not being an Indigenous person, I have had a sharp learning curve in learning, and I loved what Samara had said earlier about getting to know the person, but I would say it's incumbent on all of us who are non-Indigenous to get to know the story and the history, the Canadian history and Canadian policy, and that will help us to understand the person so much better. So I'm just going to see if I can figure out how to move there we go. So starting with this project that I want to explain to you. First of all, just to situate, in British Columbia, there are over 200 communities, First Nations communities, and they are different, I believe. I don't know the communities in the rest of Canada, but I believe they're different in that many of the communities in BC do not have treaties. And also what's interesting is that approximately 60% of the First Nations languages of Canada are actually spoken in BC. And these languages are as different as Spanish is to Japanese. And so every community is very unique and very different. And so any strategy that we came up with had to be able to be open to that. There was certainly no cookie cutter way of doing anything. And again, to Samaria's comment, is that each person and each community, each family is very unique. I want to introduce you to one of the elders that we were lucky enough to work with, Jean William. And when we talked to her about healthy medication use and reducing polypharmacy risk, this was one of her comments. In the past, our elders didn't take lots of medication, mostly just aspirin, but now cupboards look like pharmacy shelves. So I was curious when I first started working at First Nations Health Authority as a nurse, if polypharmacy was an issue for Indigenous people in BC in the same way that it is for non-Indigenous people in Canada. And so looked at this is data that comes from when an Indigenous person claims through their health benefits plan in BC. And so you can see that there's about 21% of the people who are on more than 5 medications. And so we knew that there was something that we needed a strategy that we needed. One of the challenges in all of this was that we know that there's it takes a team to manage healthy medication use. And that team, of course, includes the individual, but also a nurse, a pharmacist, and a prescriber. And for many of our communities, as you saw on the map, that were quite rural and remote. And so most communities would have the nurse and then the individual most days, but many of them would never see their pharmacist. We have communities where the pharmacy that sends the medications to them is hundreds and hundreds of kilometers away, and they never meet the pharmacist. And the prescriber, a nurse practitioner or GP, may come in to the community once a week or once a month, so they're not necessarily always there. So that's a challenge that's different from non-Indigenous people with polypharmacy risk. There's other challenges too, as I already mentioned, our Canadian policy, the history of our Canadian policy, and the Canadian policy that we still have today, and history has reduced Indigenous people's trust in the healthcare system. There's also different worldviews about health. We have the biomedical model that most of us are familiar with, but there's also, I wanted to point out, our First Nations Health Authority perspective on wellness. And this came from, you can go to fnha.ca to learn more about it. But what really spoke to me is the importance of not just physical wellness, but spiritual, emotional, and mental wellness. And often that's forgotten when we're focused on the biomedical model. And then, of course, as we've already started talking about, is lack of cultural safety and racism. Those also complicate healthy medication use. There's a fellow, Rupert Ross, who is from Ontario, and he's written some books that I've learned a lot from reading his books. And he talks about, just to say a little more about worldviews, and this concept that, and it's something new to me that I've done a lot of thinking about, is that the way I think isn't necessarily the way everybody else thinks, and that's hard to talk about, and it's hard to maybe wrap our heads around, because we have to even see that we have a way of seeing the world, to recognize that other people might see it differently. So I'd just like to read a very short couple sentences from Rupert Ross's book, Indigenous Healing, because I think it articulates it very nicely. He says that the Western scientist would focus on understanding and naming all the parts and properties of a plant. So the Western scientist would figure out its root system, the stem, the leaf patterns. It would examine how it takes in water, how sunlight and nutrients are used. It would determine how the plant reproduces, its life expectancy, and so forth. In contrast, the Indigenous scientist would look at that same plant and would focus on what the role of the plant would play in the meadow. She would focus on how the plant holds soil when the rains come, what plants flourish close to it, what birds, animals, and insects are attracted to it, and how it's useful to them, what kinds of conditions it needs to remain healthy. It's not that the two scientists would not pay attention to the concerns of the other, it's just that their emphasis would be different, and they would see the plant in different ways. So, I don't know, Samara and Alika, maybe when we have our discussion you might want to comment on this, but others have told me, yeah, this makes sense to them, that these are different worldviews. And what happens when we have different worldviews is that if we don't acknowledge that people could be seeing their experience or their health or their wellness in a different way, then there's a very serious opportunity for miscommunication. And examples of that are when there was a team of a pharmacist, a nurse, and physician would go invited into First Nations communities in BC, and we would talk to chief and council and community members about the risk for polypharmacy and what can be done for healthy medication use. And we heard things like some people would think it would be rude to question a physician about their medications. But we also heard physicians say, and other healthcare providers, that they wanted to be culturally sensitive, and so they did not want to be seen as taking things away or be seen as denying treatment. So there's tension because of our different worldviews if we don't acknowledge and embrace them. So let's get on to talking a little bit about our strategy. I've learned that storytelling has always been a traditional way in Indigenous communities to share knowledge, wisdom, and humor. And Indigenous stories often include a mix of natural and spiritual beings, including animal figures. Many Indigenous stories include a transformer or trickster character who can be both humorous and heroic, helping to teach through its mix of cunning, foolishness, and ambition. In BC, the transformer takes on many forms for many nations, from coyote to raven to mink and others. So, with help from an Indigenous nurse, Danielle Wilson, she and 3 elders from the Shwepnik Nation wrote a new coyote story. Coyote is the trickster animal for the Shwepnik Nation, and all coyote stories are very old traditional stories, but because polypharmacy is a new issue, the elders agreed to write a new coyote story for us, and they gave us permission to share it widely. I want to really acknowledge the people that were involved in this, and so our elders were Jean William, who you saw a picture at the front of one of the first slides, and Cecilia DeRose and Clara Camille, and these are 3 elders from Northern Shwepnik, and they worked with the nurse Danielle Wilson, who at the time was working Interior Health Authority, and she's now moved back to Ontario. We also worked very closely with the doctors of BC, Dr. Keith White and Margaret English, and also our pharmacist at First Nations Health Authority, Cindy Preston, and really want to acknowledge our illustrator for the book, Georgia Leslie. So this book has, and video, has been distributed at an elders gathering where over 6,000 elders gathered, and it's also been distributed to nurses and physicians, nurse practitioners, and pharmacists, with the hope that it breaks down that communication issue, where we can have a conversation that's meaningful for both people. And what we've learned from all of this are many, many things, and I hate to put them into bullet point form because that's a very non-Indigenous way to look at learnings. But what I really learned was that the best strategies came from the community. They weren't imposed. We didn't go in and tell them what they needed to do. We went and asked them what would be the best way to proceed. I also learned that Indigenous medicines are anything that protects and keeps people strong and leads to wellness. So I, prior to this, thought medicines were a pill that you'd swallow or a cream that we'd put on our skin or an injection. But medicines could be a walk in the forest, or it could be spending time by the river. All people deserve to learn how medications can make an individual strong or sick. And I think we forget that it, no matter how long it takes, people need to have the time spent to be able to understand what's going in their body or what their medicine is and why they're taking it, and what the risks versus the benefits are, so they can make that choice whether it's aligning with their values. Cultural awareness begins when healthcare providers share information about medicines and don't rush the conversation. I think that taking time, that's a really tough one in a busy healthcare system, but it's very important to create that safe space that we talked about. When healthcare providers aim to build self-efficacy, individuals will take responsibility for their health and wellness. And part of colonization is we've taken away self-efficacy. We have, as non-Indigenous healthcare providers, done for, and that's a vicious cycle that is not an easy one to break, but we need to stop and build that self-efficacy. And a person's definition of living in a good way ought to be part of medicine decision-making. Again, what a person values needs to go into whether the benefits are outweighing the risks. And in also that healthy medication use takes a team. It's not just up to the individual that's taking the medication. It's a meaningful conversation with the whole team, including a pharmacist, a nurse, and a prescriber. So if you're interested in taking a look at the book, you've seen some of the illustrations, but you can see the book, you can download it, you can order the books, and also there's a video of our elders, which it's like 6 minutes long, I think, but well worth a 6-minute watch. And you can go to any of these websites to find that at the coyotestory.ca, fnha.ca, or doctorsofbc.ca. And
Thank you,
I'll
Gina.
pass it back.
Thank you, Gina. We're going to move on now to the questions. If there's any questions out there for Gina to answer, or anyone else that would like to add. Iona?
Yeah, I'm just reading through the chat box. Alika and Samara, maybe I'll turn it over to you and see if you have any reactions or comments, or would like to add anything.
This is Samara. I would like to add, it's very important that, yes, going over the medications, we've put all of the stuff in our bodies, and we're not told a lot of times by the health professionals what can happen with it. And a lot of times we get one medication, we have side effects, and then we're given another medication for those side effects. And it becomes a downhill battle with more and more things being added and the patient getting sicker and sicker. So it's very important. And also, yes, in my culture, medicine is everything. We don't have to take a pill for everything. And I think that is a real shortfall right now in the current medical system is you go to a doctor, there's a pill for everything. They don't prescribe going out in nature. They don't prescribe talking to an elder. They don't prescribe meditation. There are so many other things that an individual can use as their medicine except for a pill.
Mm-hmm.
Just to add to that, and I think it's a really great point that when you go to a doctor, you get certain things. I mean, when I go into rooms with patients, one of the things that I explicitly try to get across is some of my biases. So looking around a room, I've already decided myself who's going to be a difficult IV start, or if you go off to sleep, whether or not I'm going to have problems with your airway, right? And I hold biases just the same as everyone else. And I think the issues that we run into is when biases are never contextualized to whether or not that applies to that specific patient. You know, are the things that we're offering actually of value to the patient that is across from us? You know, if you go into a hardware store and get a hammer, like you're going to be looking for nails because that's what hammers do. And I think as providers, we have to evolve as patients have evolved. Patients no longer just sit back and take whatever we tell them as, you know, the only way that they can solve their issues. Patients are very thoughtful and mindful in trying to co-create kind of this pathway towards wellness and health. And sometimes the system lags far behind, and sometimes providers, they haven't either thought of those steps or tried to move to that steps. You know, one of the things that Gina asked was us to reflect on, you know, the example she gave with the plant. And I'd say that it's not necessarily that providers don't see those things. It's just that providers and patients, we emphasize completely different things. You know, the full truth is everybody's experience. It's everybody's perspective. But based on our own individual experiences, we're going to emphasize certain things. Providers are going to be really focused on getting people through as far as volume. We're going to be really focused on interventions that we can do. We're going to be very focused on, you know, the patterns of care that we've gotten used to providing. And a lot of times those things fall short. And I think that patients can help us the most by pointing out some of those shortcomings, but then also recognizing that there is an emotional fragility, for lack of a better word, whenever you tell someone who puts a lot of their heart and soul into their job that what they're doing isn't working for you. You know, and so just to expect, don't take ownership for that emotional fragility. It's not your fault that we're sensitive as providers, but just be aware that that is something that we're working through. And knowing that, I hope, empowers you to work through a lot of the conflict that you will run into at some point in kind of your healthcare. But it's not necessarily that we don't see. It's just that we emphasize completely different things. And if we're going to be on the same page as far as co-creating care, we have to get on the same page with the same things. And those things have to originate from our patients.
Yeah. I think both of you, we just have a few more minutes. There were a few very specific questions in the chat box, and no wonder the participants, based on the questions we got from the registration form, come from different Indigenous communities across Canada, I think even US and Australia, based on the questions. They're interested in children as well as senior care and preventing harm and responding to harm. So we can't get into all of that, but I'll just maybe one final opportunity for each of the speakers to offer some comments, and then Marilyn to close our webinar. I'll just draw your attention to the poll that Janet has placed on the screen. It just popped up on the right-hand side of your screen. There's 4 questions. Let us know how we did on this webinar, and more importantly, let us know what more can we do in future webinars. So any final thoughts from anyone, and then Marilyn.
It's Gina. I can jump in. I guess as a non-Indigenous healthcare provider, working hard to be seen as a white ally or hopefully a white collaborator with Indigenous people, It's not an easy journey, but it's a very important journey to take the time to learn about our Canadian history, to know the story that our Canadian history has created, because it's different than what we were taught in school, and to reflect on that and how that might impact a relationship that a healthcare provider might have with an Indigenous person.
So Mary, you want to go first?
Thank you. I just wanted to say, yes, thank you, Gina, for saying that. I think that is really important. Being a university student right now, I have experienced the shock of many non-Indigenous people when they enter the classes and being taught the true history and what's really been going on with the Indigenous people. That has been left out in the history books, and that has not been taught in school. Also, all the myths out there. There are many myths that get passed from individual to individual that are outright untruths. So please do some research. You know, learn about the culture, learn about the people, learn about all those myths out there, and please try to dispel them. That is work all of us need to do, not just Indigenous people. We all need to do this.
Yeah, I'll just support the other two comments, and I'll just share a really brief anecdote. There's a program here in Alberta called the PACER program, and what it does is it takes patients and community members and teaches them about qualitative and quantitative approaches to research. So they do care mapping and other types of things. The PACER program specifically looked at cancer care in Indigenous communities this past year. And I had the great honor of sitting and watching some of these presentations. And they presented example after example of patients being ignored, dismissed, coming in, asking for testing because they had done some personal research or had family members that they discussed or talked to people within the health system that they had known. And they were told by their providers, don't worry about this. You don't have to go get investigated further. Ended up showing up with stage 4 cancer later on. I asked those patients whether or not anyone had actually reported those concerns to AHS. And I have not yet found someone who has. And these are people who have these extreme, or what we perceive as extreme experiences of care that's led to, what's probably one of the worst events that you could have as a patient. I think my final note to everyone on the call is that as a patient, recognize that you should be believed. And if you're part of the health system, you have to believe patient stories. Even if they seem extreme or out there, biases and applications of myths or other ways that we phrase it, they're really a justification for the real world experiences that people have day to day in order for us to bring reason to what is an unreasonable situation. As a provider, I'm shocked when I hear these stories, but I know that these stories exist. And I know that these are the real lived experiences of patients. And if we really want patients to share what they have to say, and we have to know what patients are experiencing in order to do better, the first place is trusting them. So truth is very, very important.
Marilyn, any final comments from you?
Well, my thoughts are kind of different. I like when it comes to medications. When it comes to let's say in Calgary, like around here, there's several reserves around here, and some of them have their own healthcare system right on the reserve, and so there's a lot of medications that get abused, and I don't know how. They get so much medication, like enough to sell to somebody else on the reserve, and they use it to get high. So, how do you deal with something like that? So that's kind of a different angle, but that's things that I've seen. And then also the carelessness of some physicians. My niece, she had surgery and she got really sick after, and they took her back, and here there was some cotton batting left inside of her. And that's another thing that's been brought up even on the news recently about doctors, that are overtired or taking some kind of drug to keep them awake, to keep going. And to be honest, I was at the Rocky View, and I seen a doctor there, and he kind of looked, his hair was greasy. He had this gown on, but it was like he was in his clothes for about 2 or 3 days, and just looking like in a panic. And I don't know. I don't know. I wouldn't want him coming near me anyway, as a physician. And these are just a couple incidences. I really believe that learning the real history of Indigenous, and one way each and every one of you could probably learn is if you ever had a Kairos blanket exercise done, and I do those a lot and educate, people in university and all across Calgary in various places. And it's not what was in the textbooks at all. It's what really happened like a long time ago, and how it's affected. Like my whole family went to residential school, and I was the youngest. I didn't go, but I'm terribly affected and traumatized from all what I've seen and what I've learned. Because my mother went to residential school. She didn't know how to do a lot of things other than what she was taught, and same with all my siblings. And there's just so much trauma there, and it's intergenerational, which that's what I am, intergenerational. And I like to teach how it's come, like the history all the way from when it was Turtle Island, the Indigenous land, and then when the Europeans came in, when the smallpox, they handed blankets around the smallpox, and it's very informative. It's very, it would help to really see and maybe even feel what Indigenous people have been through. And for myself, I've experienced, the racism, and I've had different experiences over the years, and I just lost 4 people in my family: my oldest sister, my brother, and my brother-in-law, and a sister 8 months ago. So a lot of them were in the hospitals towards their end of life, and some were treated good and some weren't. And I remember when my dad was in there and he was just on his last days, there would be nurses that would come in there. Well, this guy, he was a male nurse, and was just very rough and very, almost like almost like my dad wasn't human or something. And a lot of people from all walks of life look at Indigenous people as not human beings. So they figure they can just treat us, the way they want to, and it's not right, because we're all human beings. All across the board, we're all human beings. And so it's very, Indigenous people are very, very sensitive. They can pick a vibe up off you if you like them or not, or if you're going to help them or not, or if you're friendly or not. You acknowledge them, listen closely, because I've had people, doctors, nurses, they like it was mentioned before, talk to me, and I feel like I'm almost not believed, and I feel like
it's almost, like somebody stealing something and someone accusing you of stealing, but yet you didn't steal that item. It's kind of that feeling from, physicians and nurses and so on. And, I feel almost scared when I go into a doctor's office when I know I have respiratory issues. So when I get sick with a cold, it usually turns into bronchitis and pneumonia. And I know my body better than the doctor does. I know I've had this before, so I basically tell them what works for me and what doesn't. And they kind of just look at me and just like they want to do something else. And no, this is what works for me. So that's the treatment I would like. And but just learning the real history of Indigenous and understanding. And I would just suggest doing a blanket exercise that really comes across really, really good. Like it just helps you understand so much more about Indigenous people and how to deal with them. I think that's all I have to say. I just wanted to share a bit of things that were on my mind. And thank you, Canadian Patient Safety, for having this webinar. Thank you, Samara, Alika, and Gina for all your answers and all your presentations. Thank you for everyone else that has participated in listening and asking questions. And just keep going on this path. It's a good path. It's, it's things are really starting to come out when it comes to Indigenous. Like there seems to be more respect these days than there ever has been. And I believe that's because of the Truth and Reconciliation. Thank you.
Thank you, everyone. Let's stay connected. You have our contact information on the screen. Goodbye for now.